Okay, so currently the state of affairs, as you know, in myelodysplastic syndrome is we only have 3 FDA-approved drugs. We have the 2 hypomethylating agents, azacitidine and decitabine, that have been approved for myelodysplastic syndrome. Azacitidine has a label for improving survival in the higher risk patients and has a label in all FAB subtypes of MDS, including RAEBT, which we now consider acute myeloid leukemia. And decitabine also has a label in intermediate 1 and higher risk patients with myelodysplastic syndrome. Lenalidomide, the oral agent, a very specific label in patients who have low and intermediate 1 risk myelodysplastic syndrome with deletion 5q in the karyotype, with or without other cytogenetic changes, and transfusion-dependent anemia. So those are the agents we have. I'd just like to highlight, before we move on to things in the pipeline, some of the clinical trials that are ongoing. The GFM group, the French group, MDS group, has looked at the benefit of adding erythropoietin to patients who are receiving lenalidomide. And there was some early data reported from that at ASCO. Rami, do you want to mention that?
Sure. So because actually the original work we published as well on this, like we did a single institution study where we looked at patients that did not respond to ESAs or had a response and then the response was lost. Then they got monotherapy with lenalidomide and they had no response. And then we did the combination, and 20% of the patients, we showed that there was a response for the combination. This was also based on some preclinical work that showing that there is potentiation of erythropoietin signaling through the combination. So the French data came in ASCO suggestive of a higher response in the combination. And that's something intriguing, and I think this could be an option down the road for patients with non-deletion 5q. This is more seen in non-deletion 5q patients, that the responses could be higher in the combination.
So Alan List at your institution and Charlie Schiffer for SWOG are leading a study of exactly that. All patients receive lenalidomide and they're randomized between EPO, erythropoietin alpha or not, which is supplied by the NCI, both drugs are, in the non-deletion 5q patients to try to develop more information on this area, in this area. The French also at ASCO presented some data looking at an expression signature and polymorphisms in the cereblon gene as predictors of response. The other thing that's been done is combination studies, obviously, and we're going to talk about in a few minutes the data that's been presented at ASH this year of combinations of azacitidine with other agents, HDAC inhibitors, the IMiDs. But there is a currently accruing study that is intergroup, sponsored by the NCI. SWOG is leading it, and Mikhail Sekaras is the PI, where patients are randomized between azacitidine, 75 milligrams per meter squared daily for 7 days, versus AZA at the same dose for 5 days with lenalidomide, 10 milligrams a day for 21 days, and then a regimen that was worked out by Lou Silverman with the Alliance and CLGB, where they combined the HDAC inhibitor, oral inhibitor vorinostat, with azacitidine. There's phase 1 and phase 2 data for all of those, for those 2 combinations. I think we really need to see from this phase 3 study that's accruing very rapidly if these regimens provide a benefit in terms of complete remission, which is the primary endpoint. Study wasn't powered, though, to see if there was going to be a survival benefit, but we'll have to wait and see. Currently accruing, I think we're about halfway through the accrual.